Hello, everyone. My name is Hector Zavala. I'm the Associate Director of the Office in Boston of the National Autonomous University of Mexico. On behalf of our Director, Dr. Javier Laguna, it is my great pleasure to welcome you all to this new edition of our series of conversations in the humanities. Today, we will talk about Embracing Neurodiversity, a seminar on autism and disability studies. As usual, our colleague Mariana Imas is going to be responsible to chair this session, and she will be introducing our guest lecturers. I hope you all enjoy this new webinar and have a very nice day.
So good morning or good afternoon, depending on where you are joining us from, and welcome to this series of conversations about particular topics in the humanities that we're developing from UNAM Boston. Today, we'll be talking with 4 scholars about disability studies and autism. And let me present our invited speakers for today. Dr. Chris Denning from UMass Boston. Chris's work focuses on intervention research to support academic and social skill development and successful inclusion practices for children with autism spectrum disorders. For the past 3 years, Chris has been working with early childhood classrooms in the Quincy Public Schools to help preschool teachers implement motor development and physical activity programs for children with ASD. Chris, thank you so much for joining us today. Dr. Amy Cook is the department chair of the Counseling and School Psychology Department at UMass Boston. Dr. Cook's research team explores the development and implementation of transformative practices that promote youth development and equity-oriented outcomes, largely via community-engaged participatory research with youth and educators in partner schools and organizations. Amy, thank you so much for joining us. Dr. Mario Arias, who did a postdoc at the Broad Institute of MIT and Harvard in 2016, and is currently an associate professor at the School of Psychology at UNAM. Dr. Arias is co-founder of the Neuroscience Lab at this school, and his research focuses on neural circuit, neurophysiology, and molecular mechanisms underlying brain function and mental disorders. Mario, thank you so much for joining us today. And last but not least, Dr. Alicia Roca, who is also an associate professor from the School of Psychology at UNAM, where she is the director of a research group at the Behavior Analysis Laboratory. She is the supervisor of the design and implementation of intervention based on applied behavioral analysis for the treatment of behavioral problems in children and young people in the Association of People with Cerebral Paralysis in Mexico. Alicia, thank you so much for being here today, and thank you all for joining us and being able to take the time and sharing your knowledge with us. So I want to open this conversation, this dialogue, by trying to clarify an important concept that I'm sure is going to come up a lot in this conversation, and that is the concept of disability, right? And in particular, the idea of an intellectual disability or even neurodiversity, right? So how can we define these two concepts? What sort of things does neurodiversity illuminate that the concept of disability doesn't? I know there's a lot to unpack here, but hopefully we can start there. So Amy, if you may, thank you so much.
Yeah, thank you for having me. I'm really happy to be here today, joining you all. Very interesting topic of discussion for sure, and shifts in where we're going within the profession for sure as well. So, and when we think about diagnosis, we often refer to the DSM, the Diagnostic and Statistical Manual, which, leans toward diagnosis, that there's a disability. And so getting at this, we're shifting away from disability by focusing our attention on neurodiversity and appreciating one's identity first. And so using, for instance, identity first language when we think about folks who may be attributed to having the diagnosis in the DSM as autism spectrum disorder, for instance. So using identity first language and referring to an individual as autistic instead captures what we're noting now as being an individual is unique, or an individual wants to put their identity first, as opposed to seeing this as a disability. And so therefore, we're now referring to people's experiences as being neurodiverse. And we can therefore shift away from the limitations of having a disability and the limitations of a disability. Rather, now we're focusing on strengths and capabilities. So
Thank you so much, Amy.
sure.
Alicia, please.
Yeah, sure. So as Amy is clearly stating, disability has been traditionally understood through the medical model, which conceptualizes disability as a personal deficit or impairment, something that needs to be fixed. And therefore, it has historically been approached as an inability to engage in activities deemed normal by society. So in the medical model framework, intellectual disability refers to a deficit in cognitive capacity that impacts adaptive functioning in certain areas, such as language and other social interactions. So it's a diagnostic label that assumes that the cause of challenging behaviors lies within the individual. This is something inside the individual is wrong, placing the burden of adaptation on them. And this label, inherent to the medical model, carries a negative connotation and may contribute to social stigma and discrimination. So the concept of intellectual disability stemming from a multidisciplinary approach differs significantly from that of the medical model, which Amy said very, very clearly. And this approach acknowledges that disability is influenced by social and also by cultural factors. So it reconceptualizes disability as a social and cultural construct, emphasizing individuals' strengths. And the concept of neurodiversity is informed by this social model of disability, as you know. And the term implies that there is a diverse way of being and does not approach, for example, autism as a collection of deficits. It implies that there is a neurocognitive variation without this negative connotation or implying pathology. So there is no normal or right style of functioning, and language matters. Not only in academia, in this case, I think it's also a social justice issue.
Thank you so much, Alicia. Mario, please welcome.
Yeah, thank you so much for having me, for the invitation. It's a very important discussion about the topics that are framing a new challenges in the mental disorders and mental health. And as Dr. Amy and Dr. Roca, Alicia Roca said, it's important to reframe these new concepts, right? And they mentioned the importance of lighting the strengths instead of the difficulties. And it is very interesting that many people, for example, with autism spectrum disorder, they have many strengths. For example, some of them are very good at maths or engineering topics, and that can be a very nice way to focus this neurodiversity, right? Personally, I have met 3 or 4 people with this diagnosis of ASD, and they are super good at programming, and they have made many different programs, very unique and very good. So I think it's important to focus, to bring the light on this kind of new lens, because this kind of lens can open doors, especially in the society, right? Because as my colleagues say, the society is who is putting these barriers to exclude these kind of people. And I think as a society, as a part of the society, it's important to recognize different points of view and open these barriers. Thank you very much.
Thank you so much, Mario. Chris, please go ahead.
Oh, thank you. Thank you so much for including me in this conversation, and really excited to be here. And I agree with everything that my colleagues have said so far. And I think a couple of things that I could add to that would be, when I think about it from a school perspective and how we're supporting students in schools. In the United States, we have a process that develops and what we call an IEP. So we're developing an individualized education plan for students, and the disability classification helps us get that label and get those supports within the school. And I think one thing that I try to think about with my students is to focus on this idea of that one is this key point in all the different definitions, and autism spectrum disorder and intellectual impairment would be included, that the definition requires us to find or to see that there's an educational impact, that the student is having some difficulty being successful in the classroom. So that's one way I kind of try to pull back here and say, we're doing this to help create success for us, for our students. Sometimes I say at some level, the label doesn't really matter so much as getting them what they need. Let's be able to provide what our students need to be successful. I think that's kind of crucial to think about here. And if I think about neurodiversity with the autism spectrum, I think that's another really interesting thing to think about as well. I've worked in the field now since maybe 1996. I started working, or 1998, 99, I started kind of working with my first students. And back then we had this umbrella. There was the umbrella of autism. It's become kind of the spectrum. And part of that is from when Asperger's disorder was added in the mid 90s, and that kind of spread out. We have a broad range of characteristics, from individuals who are very impacted and maybe nonverbal, to individuals who are very gifted in many ways, but still share some of these common characteristics. So it's a really broad category of students and individuals that we're thinking about here. And lastly, I think one thing I like is teach programming. I don't know if people are familiar with that, but that's North Carolina systems use all kind of teach training. And teach, the acronym is always confusing for me, but it stands for Treatment and Education of Autistic and Related Communication Handicapped Children. And I've been to some different trainings and really enjoy thinking about the perspectives there. A lot of it is building supports, building structures in place. But one key I like from them, I think is relevant here, is this idea of a culture of autism. And teach thinks about this idea that we value the individual, and we're not trying to change the individual, but we're simultaneously adapting the environment to help them be more successful, and we're adapting the individual to the environment to create success. And by that, I mean, we're teaching them skills to be more successful in the environment. And those are some kind of ways I like to think about this.
Thank you so much, Chris. And let me stay with you for a little bit longer. So we can move to the second question for today. That is, well, how can we define ASD, right? And sometimes actually, you know, we see autism spectrum disorders as plural. So how can we understand, is it just one big term? You were talking about this umbrella term. Do we now have different ways to classify this neurodiverse way of being? So please, Chris.
Yeah, that's a really interesting question. I think that we're thinking about defining autism. In 2013, the Diagnostic and Statistical Manual, the DSM, as Amy referenced earlier, rethought of the definition for autism. And they, rather than having separate categories, and we used to have autism, Asperger's disorder, childhood disintegrative disorder was a part of that. Rett syndrome, if folks have, that's another kind of relatively low incident. Pervasive developmental disorder was part of this group. So there's all these different categories that we're thinking about, and each one was overlapping and unique. And I wasn't really part of that group that made this change. But one thing they were thinking of, one area I think they were thinking of that they talked about was this idea that we really weren't finding, especially on the Asperger's disorder, the area of Asperger's disorder, the research was struggling or inconsistently was finding that whether or not we talked about a student having Asperger's disorder or talked about a student having high functioning autism, that our interventions were the same. How we would support them would be the same. And practitioners frequently were not consistently applying the definition, the characteristics. So we weren't always, we would work with a student that was labeled as Asperger's, but maybe not know exactly what that meant. So I think they felt this idea of kind of this more broader term of autism spectrum disorder seemed to make more sense for a number of reasons. I think it also helped, the idea was also to help people get more consistent supports, maybe more easily to get supports from systems like ABA or medically have insurance provide supports for them. And I think maybe the last thing I'll say, and I'll let others go in, one area we think about for the characteristics of autism is that it's really a social and a communication based disorder, and that individuals really struggle or can struggle in different ways with communication and social interaction. And that can fall under social emotional reciprocity, the give and take, nonverbal communication. So much information we get non-verbally, and that can be an area of challenge for some of our students with autism, individuals with autism, and an overall idea of this relationships, trying to support relationships. So those three areas are kind of key to think of challenges that individuals might have and ways to help them be more successful.
Thank you so much, Chris. Amy, please, if you have something else to add.
Yeah, sure. It's a great question that you presented, and just adding to what Dr. Denning had shared with us about sort of the wide spectrum of types of characteristics and level of functioning of folks. And I think this gets to your question around how we're defining it and where the field has gone, right? And so the DSM characterizes the functioning in terms of levels, level 1, 2, and 3. And we think of level 1 as being less severe, with level 3 being the most severe on a line, right? And so, but it can be limiting if we take this approach, as opposed to where now the field is moving toward is the use of a pie chart. If we think about level 1, where they're quote unquote higher functioning, let's say, folks' characteristics or level of functioning can result in practitioners and educators and so on, perhaps missing some other important aspects that where individuals might benefit from support. So, for instance, we know that we may not observe someone who could be characterized as having the level 1 characteristics, and may educators and practitioners might not see that individual or understand the kinds of supports that they could benefit from. But we do know that those individuals, they are at greater risk compared to the general population in terms of experiencing mental health challenges, including issues related to suicidal thoughts, or they could experience greater bullying in school settings. They could experience abuse, or later on in life encounter challenges with career. So I think we're missing some of those things. And at the same time, a linear model fails to capture the fact of that there are, as we were speaking about earlier, strengths that individuals possess in terms of their abilities and capacities. And so instead a pie chart allows us to, it captures 10 different characteristics while not capturing all of them. It does provide an opportunity for us to see or appreciate where an individual might have varying capacities and strengths, and then on the contrary, areas where they might benefit from support. So I just wanted to mention that in terms of how it could be useful for educators and practitioners and for individuals within the community when they're advocating for their own self needs and what have you. So, yeah.
Thank you so much, Amy. So Alicia, oh, Mario, please go ahead.
No, please, we can continue
No.
with Dr. Roca.
No, please,
No
please.
problem. Well, in my comment will be very, very brief. So I just want to add that in this DSM, the new version of the DSM, the Manual of Diagnosis, it was included also the domain, the sensory domain, based on the clinical experience. The physicians started noted that 90% of the patients or the people who has this diagnosis of ASD also present these sensory disturbances, right? So it is the first time that is included, and I think it's important to mention because this new avenue opens new opportunities to face and the challenge of detection and the diagnosis, right? So I just wanted to add that point. Thank you.
No, thank you so much, Mario. That's perfect. Because that was going to be sort of the next topic, right? Because Amy sort of touched on it, and I wanted to also ask Alicia what she thinks about, having now this pie chart with different categories, and you can grade each category instead of just having this continuous line, as Amy was saying, where you just have like the not so bad cases and the really bad cases. And so how can that sort of reframe the way that we think about, autism and maybe even other disabilities, if we can call them that. So Alicia, please.
Yeah, I think once we understand autism as a variation in neurocognitive function, perhaps there is no need to label the not so bad or really bad cases. Because both classifications are based on comparisons with behaviors within normal. Our purpose is to help individuals, as my colleagues were saying, improve their daily experiences to maximize their potential and overcome obstacles, rather than assimilate or behave normally. This should never be the goal of an intervention, as Dr. Denning was explicitly saying. So the categories of not so bad and bad cases, again, remind us of the medical model and the alleged collection of deficits. And making such distinction may imply pathology and contribute to labeling individuals. However, charts can be useful tools. They can help us understand the topography or intensity of challenging behaviors and identify areas that require attention in order to design interventions that help to improve the quality of life of those we serve. So this involves changing or creating environmental conditions to assist individuals diagnosed with autism and maximizing their potential, overcoming obstacles, and in general, thriving in crucial aspects of their lives. So, for example, us behavioral analysts are consistently reminded to start by identifying the strengths of the individual and to center the interventions around building upon those strengths, rather than focusing on eliminating behaviors. So it is crucial to tailor treatment to align with the participants' values and special interests, and of course, their strengths.
Thank you so much, Alicia. So let us move on a little bit also to the idea of the diagnosis, right? So preparing for this webinar, actually, I found this very interesting data that, traditional estimates found that boys are 4 times as likely as girls to receive an autism diagnosis. And I found that, recent research shows that nearly 80% of autistic females are undiagnosed as age of 18. So can you all explain us a little bit more why this happens? Why does diagnosing autism vary so much depending on what sex you're assigned at birth? So Mario, if it's okay, let's start with you.
Sure, thank you very much. Yeah, it's a very important and very interesting question. I think that the problem started, it has like a historical related thing, right? Because the first cases were identified in males. For example, Leo Kanner, even Asperger, identifies this group of symptomatology in males. And I think since that moment, we started having this like a bias, right? I started thinking about that the ASD is not only, but more prevalent in males. And on the other hand, also the research started more focused on males, but not only humans. I personally study this the ASD in animal models to identify and reveal the molecular mechanisms and neurophysiological components, etc. But also in an animal models research, there exists that bias. There is only a few studies that put on the table the data from the females, right? So in summary, I think we have had this like a bias to not see what is happening, and this has impact first the tools that we have for diagnosis. These tools, the actual tools, the clinical tools were also validated and proven in males, right? So the clinical experience also has been more in males. So I think we have to bring more tools and to have more information about how the ASD has been expressed in or is expressed in females, and then incorporate all of this information to develop new techniques for detection, diagnosis, but also for the interventions, right? Because there is evidence that the clinical manifestations are different in females, right? And can be mimicked or can be camouflaged in their behavioral expressions, thoughts, and there is a lot of information related with this. And I think it's important to bring this to the table. Thank you very much.
Thank you so much, Mario. Amy, please.
Yeah, thank you. Yeah, as Dr. Arias was just talking about, in terms of there being, the research focused primarily on boys and men. So we need to improve that research and those gaps there. And in addition, as Dr. Arias was talking about as well, just thinking about some of the expectations that are placed on girls and women are, they're a bit different from a societal standpoint, right? So, and that contributes to some bias. So we have different thoughts about how girls and women behave socially. They can also mask their uniqueness, their neurodiversity. And so they may exhibit eye contact or smile, right? And or just be able to, some of the aspects that we tend to think about in terms of ASD, we're not noting them, as well as we think too, our expectations about girls and women are that they tend to be quieter. And so that presentation as well might mislead us, and then therefore think about other diagnoses for girls and women, such as depression, anxiety. And so we might be overlooking what might be really happening, which is unfortunate, because if we can intervene early, then we can support the development of their neurodiversity as in a supportive and positive way. And so I think I just wanted to add that additional piece.
Yeah, thank you so much, Amy. And I was even thinking, you know, the chart can also help with this, right? Instead of the continuous line, to sort of recognize other types of characteristics and not just one, right? So Alicia, if you want to add something, please go ahead.
Yeah, the autism diagnosis, of course, is based on behavior, and of course, behavior is a combination of genetic factors and a history of environmental events. This is the girls and the boys' upbringing. So in terms of genetic factors, it's possible that differential sensitivity, for example, to certain stimuli for girls and boys, contributes to the occurrence of behaviors considered symptoms of autism. For instance, the findings of some analysis indicate that boys diagnosed with autism often exhibit limited play interests, for example, focusing on or manipulating specific toys. And in contrast, girls tend to display less restricted interests in objects. Dr. Cook was saying something very important, that is regarding environmental events, such as upbringing. The issue of social norms and what is deemed normal becomes pertinent again, particularly in the context of gender. For instance, introversion may be considered as a symptom of autism for boys, but not necessarily for girls, as introversion or shyness may be more socially acceptable for females across many cultures. And this disparity in diagnosis rates has led to the argument that girls are often underdiagnosed with autism. This may highlight the influence of social and cultural perceptions on diagnostic criteria, rather than solely differences in the prevalence of autism between genders. I think this question is really, really interesting. And of course, this is an open question requiring further exploration.
Thank you so much, Alicia. Chris, please, if you have anything to add.
Oh, I think my colleagues have given such thorough answers. I'm not sure there's much more to add, but clearly I do think that the research would suggest that we're under-diagnosing girls. And it doesn't appear that it would get us to a 1-to-1 correlation, but we're certainly under-diagnosing girls. Maybe it's 2-to-1 rather than 4-to-1 would be the ratio. And I guess the only thing I would add to that is say, this is similar to other genetic linked disorders or genetic linked challenges that students may have in school. If you look at learning disabilities that boys are much more likely to be diagnosed with a learning disability as well. I think researchers would suggest that that's partly due to the XY chromosome, that the genetic factor will impact a boy more than a girl. But I also do think boys are just probably doing things that make it them more likely to be diagnosed, and that girls are masking, girls are following directions better, are kind of engaging in what's happening. But really important that we make sure we're getting kids what they need. And if we're underdiagnosing girls, then we need to look at that more.
Thank you so
closely.
much, Chris. Yeah, thank you so much. So staying within the topic of diagnosis, I also found that, you know, the CDC report says that, you know, diagnosing kids with autism continues to grow and has continued to grow. So I have just a couple of data. So in 2014, the CDC report said 1 in 54 was diagnosed. In 2018, 1 in 44, and in 2020, 1 in 36. So can you all tell us a little bit more about this, right? Why does this number keep increasing? Do we go back to our tools, right? Do we have better tools to diagnose autism, or is there something else going on? Chris, let's start with you now, since you were last.
Sure, thanks. Yeah, this is another really important area to think about. And what I tell my students is, it seems to be that we have both better diagnosis, changing definition, and increasing prevalence. So that's actually three different things are occurring that I think are leading to seeing more individuals diagnosed with autism. And I was seeing this in early 2000s. I was working as an autism specialist across schools, and my caseload was increasing, almost doubling each year as I continued to work with students. And one, you could look at our definition of autism continues to change. So in 1994, Lorna Wing, a researcher, kind of brought us back to think about Hans Asperger's work, and Asperger's disorder was added to the DSM, and that kind of expanded the definition. So you kind of immediately had a jump there. If I look at the definition in 2013, that to me looks more expansive. I think the research was saying they didn't think it would necessarily increase it, but I was like, well, why would it not? You've now collapsed pervasive developmental disorder into autism. So you've taken what we used to kind of say, well, that's not autism, and I don't know if I was doing the right thing then, but it was different, but now it's part of it. So I think we've expanded on what the definition is for autism. I think people are more aware of it. So they're thinking about it's on people's minds. We have another definition in, at least in our schools in the United States, of emotional impairment. And there's a real stigma to an emotional impairment to diagnosis. So I think families would probably lean toward autism if they could. I've worked on teams where we've changed the definition because there's clearly not, a kid was mislabeled as having an emotional impairment, and autism was a much more accurate label for them. And lastly, I'll say, it does appear that we are getting more complex kids in schools as well. Different allergies are on the rise, different things are on the rise. There's some evidence to suggest, as parents have children at older ages, there's more variability there, and kids may be a little more complex because of that. So it seems like multiple things are occurring that would lead to our increase.
Thank you so much, Chris. Alicia, if you want to add something, please.
Yeah, I don't have much to add to what Dr. Denning just said, and I agree that this increase in the prevalence of autism is due to many combining factors. I would only add that the analysis of prevalence of autism are mostly based on registers from high-income countries, in which autism diagnosis and disseminations to raise awareness about autism and professional services are more readily available. So studies on prevalence of autism in lower income countries are somewhat inaccurate and limited.
Thank you so much, Alicia. That's very interesting. I wish we can say a little bit more about that if we have time. Amy, if you want to add something.
Yeah, and it was interesting what both Dr. Denning and Dr. Roca had just shared. And, you know, here in the United States, there's also the prevalence varies by state, sort of similar to what Dr. Roca was talking about. And that prevalence, the difference has to do with the varying levels of awareness of autism, but also the varying levels of services offered by states. And so we see where there's greater awareness of autism and greater levels of services in states that we have a higher prevalence rate. So I think that speaks to what Dr. Roca was mentioning from an international standpoint. I do want to say too that, so there was a shift in 1991 in terms of eligibility for special education services here in the United States, whereby ASD could qualify students for special education services. Starting at that date, prior to that, you had to have a diagnosis of intellectual disability or impairment in order to qualify. So, and furthermore, you can have multiple diagnoses from the DSM to qualify for special education services, whereas before previous versions of the DSM, you could not. So, you know, I want to say there are a lot of different reasons for why we're seeing an increased prevalence, because there is a change in the diagnostic criteria. It's growing awareness. There's also literature to suggest that low birth weight could be a contributing factor. So that might speak to what Dr. Denning was mentioning in terms of older birth parents, because we know that that could be a contributing factor toward low birth weight. Stress is another area that has been documented. So a lot of different factors are contributing overall, I would say. So.
Thank you so much, Amy. Mario, please.
I think my colleagues have plain and put the important key concept on the table. Thank you very much.
Thanks, Mario. Alicia, if you can say a little bit more about this, you know, difference in diagnosis between, you know, first world countries and third world countries and how that varies. Just expand a little bit more on what you were saying, because I think that's very interesting.
Yeah, sure. In Latin American countries, for example, in Mexico, there are limited services. So autistic children do not receive this diagnosis from professionals who know how to diagnose autism, for example. The other issue is that the registers are really inaccurate. There are disparities. So we can't trust them very much. And on the other hand, they're very limited. We have limited access to that kind of information. So I think those are the three main problems.
Thank you so much, Alicia. And well, this actually makes me, you know, go into our last question and our last question to open the conversation, and that's about, you know, of creating inclusive environments in classrooms, particularly for children diagnosed with ASD. And you know, Chris, you have worked a lot in public schools, so if you can tell us a little bit what's happening in the U.S. and the Boston area in particular about, you know, more inclusive schools and environments. And you know how realistic this is at a national level, right? Expanding this at a national level, and then Mario and Alicia can tell us a little bit more about what's happening in Mexico as well. So please, Chris, go ahead.
Oh, sure, I'd happy to. Thank you so much. It's complicated in many ways, I think. And yes, I've worked with including kids with autism for a long time. My first classrooms, I was in a self-contained classroom working with students who hadn't been in the gen ed room in a year or two, and I immediately started putting them into the gen ed classroom and trying to see how well they could do and providing more supports. And my goal was to continue to put them in. I've written a book on this topic and was looking back at an article that we wrote. So I've been thinking about this for a long time, and I think in general, we're moving toward a much more inclusive environment. And that is definitely the direction that we need to go. We're especially doing that with individuals with autism and intellectual disability and other more severe disabilities, as well as we move them out of hospitals, out of residential programs as much as we can, and bring them back into their home school, their neighborhood school, as much as possible. I will say I do though think there's the power and the need for a continuum. I do think especially we think of a continuum of placements and really looking very closely at the student and what they need and where that can be provided to help them be most successful, and to start with the gen ed classroom and then to push them out into other settings if they need it. So I do think we have to think about that. Many schools around Boston are trying to be completely full inclusion, having many kids in the gen ed classroom, though they often do have strands with kids with autism. So they are doing both, more inclusive and more not. And I think that's important. I think starting in the gen ed room and then supporting out. And I'll just say one more thing. I don't want to take up too much time, but I think there's a paradigm to think about and how to help kids be most successful in the gen ed classroom. And one way I've written about this is to use a universal design for learning, if you are familiar with that. And that gets this idea of kind of a baseline, kind of a tier one, what we would do in the gen ed classroom for support all kids, and kids with disabilities will be supported there as well. I flip it, and they often have engagement as the last thing. For kids with autism, I kind of start there, and I say, if they're not engaged, they're not learning. So let's start with engagement, and we think about big ideas like schedules, very structured, routinized classrooms, using their special interest to get them hooked on things, and using this idea of priming, which kind of lets kids know in advance what's happening. Here's what we're doing today. Here's what we're doing at 2 o'clock today. Here's what math class will look like. And that's been super powerful. A lot of kids I've worked with, working with representation, so schedules and visual supports and organization for things. And then expression, multiple means of expression is another dynamic of it. And that's like structuring assignments, making it everything's got to be really structured for our kids with autism, especially in the inclusive classroom, to help them be successful, and adding choice, the power of choice to help them get more engaged. And then you can do more intensive things. But if you start there, you've got a great inclusive classroom where kids are more likely to be successful. And last thing I'll say is independence. You've got to be starting and thinking about independence all the time, and how you can provide just enough support so they're successful, and be always thinking about pulling back so that they can do it on their own. If we're thinking about those ideas, I think we can create an inclusive gen ed classroom that kids can be successful in.
Thank you so much, Chris. Amy, please.
Yeah, thanks. Well, yeah, Dr. Jennings shared quite a bit there, so covered a lot. I think one thing I'll just add, so my background is counseling, and that's my training area. And so I think one additional piece I'll add to thinking about inclusive classroom environments is having counselors, provide support within the classroom, could also serve as a collaborative team member with the teacher, and thinking about ways to engage students, all students in the classroom. So when thinking about, for instance, like group work, thinking about the pairings that the students are grouped together in, being on the lookout for isolating kids at unstructured times like recess or free play time, or being on the lookout for bullying and things like that. You could also run small groups of special interest for kids to support them, including all kids. So the small groups wouldn't just need to include kids who are autistic, but also a variation of children around special interests, as opposed to social skills, let's just say. So something that's of interest to a group of students and having them get together. So I think of all those things that Dr. Jending was sharing, and just thinking from the counselor lens, how counselors can be helpful in supporting teachers and supporting students in the classroom.
Thank you so much, Amy. So Mario, do you want to share a little bit more about, what's going on in Mexico regarding this?
Sure. Yeah, I think we have some challenges over here. First of all, our public system of education, I think many of the classrooms are very big. We are talking about 40, 30, 40 kids per group. So it's difficult for teachers to keep control of all of the kids and be aware of the different strengths and special needs that the kids have, right? And there is also some public places where ASD kids can have this special education, which is called USAER. I don't remember the specific full name. But for example, in this model, kids are mixed. I mean, there are kids from 6, 7 to 12 years, right? Sharing maybe one teacher. And the other possibility is to have private education, right? Where you can provide more specific and more detailed education. But generally, these kind of centers are expensive. So the possibility for the kids to get this kind of education is very limited, right? So I think we have different challenges, depends on the possibilities of the families, is the education that the kids can have. But also in general, I think that the awareness of the ASD symptoms, needs, strengths, in general, in all of these educational systems, I think is very important, because that will bring a different lens to have the consciousness, and then provide guidance and help, right, the kids. But I think we have many challenges. I'm talking about the education in Mexico for this kind of.
Thank you, Mario. And Alicia, please.
Yes, I agree with Dr. Arias' analysis of the situation here in Mexico. And I can talk about my experience working with individuals diagnosed with a comorbid diagnosis of cerebral palsy and autism. And economic hardship among families is an obstacle to that impedes, is a barrier to this inclusive classrooms. For example, cerebral palsy places a significant financial burden on families, most of whom have a low income. And for example, the expenses for these families include medical services, physical rehabilitation, medication, special education, and assistive devices. So there are many, many things. And that is a first barrier. The second barrier, I think, it's a conceptual one, because in Mexico, most families seek medical services for the treatment of challenging behaviors, which are often based on psychiatric diagnosis. So, for example, in the case of individual with a comorbid diagnosis of autism and cerebral palsy, it is often assumed that the alleged disorders originate from a brain lesion. So for families and teachers, it doesn't seem that there is much to do. And it perpetuates the false notion that something is wrong with the individual. So I think that the key to creating more inclusive environments is to promote a scientific approach to behavior. And we need to emphasize in diversity. We need to give people this sense of optimism based on the results of a scientific account of behavior. And we need to shift the focus from trying to change the individual to modifying the environment in which they live, because it involves mainly understanding the contingencies that maintain challenging behaviors and act as barriers for individuals, and then arranging new ones to support positive outcomes. So that is crucial in my opinion. I think that collaboration with nonprofit associations dedicated to assisting families from different socio-economic backgrounds is essential for disseminating this scientific approach to behavior and emphasizing the necessity of creating environments that support each individual's needs. That in many cases, it does not require money. Just an understanding of changing the environment in which the children live.
Thank you so much, Alicia. And well, that's all that we have time for today. I wish we could keep talking. I have many questions that came up from this conversation, but I hope we can, plan another seminar where we can also explore that. But Mario, Chris, Alicia, Amy, thank you so much for joining us today and for sharing your knowledge and for being part of this conversation.
Thank you for having us.
Thank you.
Thank you.
Thank you very much.